Thank you, Chairperson, for your kind introduction. My name is Erika from Kyoto University. I'd like to thank the organizers for giving me this opportunity to speak at this wonderful Congress in the beautiful city of Beijing. So I have nothing to disclose. So I like to switch gears and I like to speak from the bedside. So we use clinical studies data, biomarkers, clinical data to really bring back the data to bench, and then that will lead to drug development. So we take more of the causality related, disease related clinical, that is more often we take a approach from the clinical needs. So a little bit different approach. So for today's topic, I chose inflammation. It's not the newest topic. It's probably one of the oldest pathophysiology known in the human from the ancient days. But currently, chronic inflammation that affects the systemic organs, including heart, is becoming a worldwide problem. So there are various causes for inflammation, including smoking, but currently the attention is on obesity, which has become modifiable with the advent of newer drugs. So as you heard from Dr. Shu, there's an obese pandemic. Approximately 650 million people worldwide is obese in 2060. And it is projected to elevate to 1 billion by 2030, which is in prevalence 25 to 40% in developed countries, and also high level persist from a younger age and accelerate multimorbidity. So there are multiple obesity-related health problems as listed here, not just cardiovascular, but also non-cardiovascular. But we could probably divide by fat mass disease, which is the volume itself is a problem, and also the six fat disease. And when we say about six fat disease, it's really we talk about fat as it's something bad, but it's not. It's very important in the body. It's a major fat storage reservoir, and it possesses anti-inflammatory effect in the healthy individual. But in obese patients, the adipocytes become hypertrophic and becomes hypoxia. It induces hypoxia necrosis, which of course leads to mitochondrial dysfunction and systemic inflammation and causes cardiovascular diseases and other diseases. So there are increasing awareness of the body composition, importance of body composition, because visceral adipose tissue is more complex, has more complex and intense inflammatory response and higher macrophage content compared to subcutaneous adipose tissue. So BMI itself is, of course, is a great marker. But for example, for Asian people who has a lower BMI, body composition may be more important because of, I think in Asian people, we have a higher prevalence of central obesity. So there are multiple studies that are being done in looking at the relationship between the cardiovascular and obesity. For example, this is looking at the epicardial adipose tissue and association with the onset of atrial fibrillation and also HFpEF. And also perivascular adipose tissue, which is thought to be related to coronary ischemic heart disease. And also there are increasing awareness of the importance of obesity in the heart failure patients, particularly in HFpEF patients and obese patients. So we know that adipose tissue has local RAS, which directly and indirectly elevates angiotensin II, and which activates RAS system and leads to heart failure. And also there are changes in the microbiome, which is thought to be the cause of systemic inflammation and atherosclerosis. So the AHA presidential statement has stated that the obesity is no longer a risk factor, but it is a disease which needs to be intervened early in life. And there has been in multiple decades of efforts trying to develop anti-obesity drug. However, most of them were discontinued or withdrawn from the market because of the safety reason. But the landscape has changed with the advent of GLP-1 receptor agonists, as some of the speakers has already noted. It's an incretin which has a central role in glucose homeostasis. So this was developed as an anti-diabetes drug, but now it is being developed as a anti-obesity drug. So here you can see a result from some HFpEF trial is testing tirzepatide in in obese patients, and as you can see, there are about 15% body weight reduction, as well as 40% reduction in high sensitivity CRP, the inflammation marker, and which we think might probably and possibly might have caused the reduction in cardiovascular death or worsening of heart failure, as you can see here. So currently, there are more than 400 drugs that are being developed as an anti-obesity medication. You can see some of them here. This is mainly it's incretin-related drugs. But one of the problems is that it leads to a muscle loss, and now there are efforts to combine this muscle preservation drug with this anti-obesity drug, which is very interesting. But some of them do have seems to have a safety problem. Other anti-obesity mechanisms, including metabolic modulator, PYY agonist, gene therapy, and of course GDFT may be one of them. And there are very interesting for me there are ongoing and potential indication expansion of GLP-1 receptor agonists. So we started out with anti-diabetes drug, but expanded to anti-obesity drug. Now they're moving into another field, for example, neurodegenerative disease like Parkinson's, or alcoholic or tobacco use disorder, and depression, schizophrenic, bipolar disorder, which you don't directly sort of think from the mechanism action of the drug. So it is very interesting and very promising field. So maternal obesity, of course, is one of the problematic field as well. So maternal obesity usually leads to childhood obesity. So the field is now moving into primordial prevention again. So looking from clinical studies and clinical biomarkers, and this has the opportunity to really open up or expand the indication or repositioning and find a new mechanism, which might be very interesting. So we use a lot of biomarkers, but biomarkers are really challenging. I had a lot of challenge with this. So GDF-15, as Dr. Shu has already mentioned, it's really a interesting biomarker. And it's a TGF, it's a member of the TGF beta superfamily, and it is weakly expressed in the cardiovascular tissue, but it's created with stress and inflammation. That's part of the reason why I asked the question to Dr. Chu. So, and GDF-15 is really an excellent biomarker for heart failure prediction and cardiovascular death. So for a drug, so GDF-15 induces, we knew that GDF-15 induces body weight loss, but we did not know the receptor for GDF-15 until quite recently. So now we know that there is a GFRO in the brain. So that's why I asked the question again. So we know that this part is controlling the appetite, and is very important for body weight. So this has been developed. Partly I propose for this as an anti-obesity drug with Novo Nordisk, and the experiment was good, and the primary data was really good. Of course, it loses body weight, but unfortunately, the same company was investing for semaglutide, incretin base, and unfortunately, they had the greater body weight loss, so they dropped the GDF-15 as an anti-obesity drug. But interestingly, the other company found a promising field for GDF-15, so not really so GDF-15, so blocking anti-GDF-15, which is very interesting. So we knew that in cancer patients GDF-10 is elevated, and that from preclinical studies we knew that the tumor secrete GDF-10. So what they did was, and we knew that in cancer patient GDF-10 GDF blocks T cell endothelial cell and prevents T cell infiltration. So they thought that by blocking GDF-10 in cancer cachexia patients, they could probably improve anti-tumor response as well as increase appetite, improve weight gain. So two effects with one drug. So that's what they did. So this is a phase 2 study looking at GDF-10 ponsegromab for treatment in cancer cachexia patients. And as you can see, it was a largely positive, promising result. You can see that there's an increase in body weight with ponsegromab. But the story is not so simple. So there's an anti-GDF-10 the same company tested anti-GDF-10 for heart failure. I was not part of this. So very interesting that the result was presented just a few weeks ago. It is not being published in the paper yet, so I only know part of the result. But very interestingly, GDF-10, by blocking GDF-10, it increased cardiovascular death and it worsened heart failure. It was mainly driven by the worsening heart failure. So you can see there are almost 2.5 or 2.84 fold increase in heart failure. Very interesting. So again, the paper is not published, so I only have limited information. But here are some of the population that was being studied. So BMI was 25. In Asia, 25 is not so obese or not cachexia. Only 30% met criteria for cachexia. So they tested in RAF patients. The median value was 35. NT-proBNP 2,155, not too high, not too low. And there was an increase in 1.4 kilograms in this population. And interestingly, high sensitivity CRP was elevated by 1.5 fold. So very interesting. So I do wonder if this was right patient, right dose, right disease. So we always have to think about this kind of thing, whether it was a mechanism itself or do we find the right patient, right population. So, but we sort of knew that this was coming because we tested GDF-10 in DAPA-HF trial, which was of course HFrEF trial, and we did not see that DAPA that had any effect on GDF-10 level over 12 months. So we sort of knew that GDF-10 was not really causal in this population. But the inflammation story really was inflated by CANTOS trial. Of course, everybody knows about this trial. It's testing canakinumab in ASCVD patients, and you can see that there was a decrease in high sensitivity CRP, which is thought to be causal for and people who had who achieved a lower level of high sensitivity CRP benefit more in terms of decreasing MACE and heart failure. And this was supported by the trial result from Colcott and Lodo-Colhitin, which reduced MACE and also reduced high sensitivity CRP. So there is still hypothesis that inflammation plays a large role in ASCVD patients. So we tested LOX1, lectin-like oxidized low-density lipoprotein receptor 1, which is known for decades. LOX1 is pattern recognized scavenger receptor for oxidized LDL and other DAMPs, and of course it is highly related to inflammation. So by blocking this we thought that we could prevent atherosclerotic disease progression. So we tested a drug called MEDI6570, and this was published just a couple of weeks ago in Nature Medicine. Unfortunately, the trial was terminated early. So we did see a reduction in high sensitivity CRP. So hypothesis proven. And also we saw that the LOX1 was also reduced. But as you can see from here, there was no change in non-calcified plaque volume. So again, it's very complex. We thought that the inflammation is very complex. Now there are groups looking at the NLRP inflammasome pathway, which is thought to be the main target for the cardiovascular disease now. But again, our data was neutral, but I think we gained a lot of information from those trials looking at which pathway really works. So we are going back to the mouse model and basic research to understand really the association between the inflammation and cardiovascular disease. So looking ahead, there's another trial with anti-IL-6 trial, which I am an investigator, but I'm not the leading one, ziltivekimab. They are doing 3 trials, patient with cardiovascular disease and CKD, patient with ACS, and also a patient with HFpEF and inflammation. So we'll see how it goes. This will definitely give a definitive answer for inflammation and cardiovascular disease. So take-home message for me, from my side, it's inflammatory pathways most likely differ between obese and non-obese individuals. The interplay between obesity and inflammation is important to cardiovascular disease pathogenesis. And in obese individuals, inflammation often reflects metabolic overload and also adipose tissue dysfunction. But in non-obese individual, inflammatory activation may involve a more heterogeneous and complex mechanism. Thank you so much for your attention.